Welcome to Face Health Talk Show. Today's informative session is about lung transplant. But before we start, I would like to invite my co-host, Dr. M.S. Kanwar. He is pulmonary and critical care specialist and senior member COVID team from Indraprastha Apollo Hospital, one of the best hospitals in India. Hello, Dr. Kanwar. How are you?
Yeah, hi Rashmi, how are you? In fact,
I'm
after a
good.
long travel, you're looking fresh again. Uh,
This is my
Thank you for
favorite
inviting
show,
us for the show.
Dr.
Yeah,
Kanwar, and I feel a little bit
yeah,
contribution from my Dream TV USA for our viewers. Thank you.
yeah, perfectly. Uh, Today, Rashmi, we are going to talk about lung transplant, some of the issues on lung transplant. Though people in America are uh, much wiser on these issues, and they have a lot of transplant centers across North America, and they obviously they can read all about that on the, the internet, and they do that. But the idea of bringing two of the best people here, one is a master. Dr. SundeR is a master surgeon who has done a huge number of lung transplants, probably the maximum in India, lung transplants in India, and also a very noted heart lung transplant surgeon. He is the director of this program in Chennai, Apollo Hospital, Chennai. And we also have my colleague here from Indraprastha Hospital, Delhi, the young, budding, energetic Mukesh Goel, who is a lung transplant surgeon as well as cardiovascular surgeon. He has done a couple of heart transplants also.
Very
So,
good.
and he was with me in Toronto when we had gone for training
Okay.
for lung transplant. And Rashmi, at our age, we were working like residents there. When you want to learn something, you really have to go deep into that and be a student. And even if you are in 60s, if you are a student, you have to work and learn like a student. So that was fantastic. And Mukesh would be you know a co-surgeon in the beginning, and he'll be kind of trusting the lung transplant program at Indraprastha Hospital, New Delhi. I must also tell you that we recently formed the Lung Failure Association of India, and Dr. SundeR is the vice chairman of that. And I'm glad, Dr. SundeR, you accepted that position. And of course, Dr. Mukesh would be in the academic council. And so we will be working actively on that. And we have actually also already done a couple of webinars for awareness and educational purposes for the physicians across the country. And we are due for a symposium, full symposium, for 2 days in a month's time. It would be in the first half of September. So that is our academic pursuits and programs as connected with lung transplant or end-stage lung disease or lung failure is concerned. Um, uh, let's start with Dr. SundeR.
Welcome, Dr.
Dr.
Kanwar.
SundeR, yeah, you have
Well,
uh,
thank you, Rashmi and Dr. Kanwar for inviting me. Indeed, it's a pleasure for me to take part in this face-to-face talk. And yes, Dr. Kanwar, please go on.
uh, Dr. SundeR, tell us what kind of surgeries you have performed for a lung transplant. Means what kind of patients you had. We know internationally what is the group of patients that form the bulk of end-stage lung disease ready for lung transplant. But what has been your experience, and what kind of cases you prioritize?
Yeah. Um, I'm going to, as we discussed before at the beginning of the show, try to keep my talk, um, you know, um, probably appropriate to the people who are non-medical as well. Any transplant for that matter, not necessarily the lung, is advised only only if the said organ has reached a point of no return. It has reached that level of failure that no current available treatment can help it anymore. When there are no other options available, we suggest transplant. So if we come to the lungs, lungs which are ravaged and destroyed by many causes, as a result causing an end-stage lung failure, would be the patients on whom we do the transplant. I would hasten to add that transplant is a salvage operation, and it is an operation when no other treatments are available, because transplant by its very nature is a sort of a barter, is a sort of a business deal, wherein in order to get the good function of a new organ, the patients give up something from themselves, and which is giving up their own immunity. And as you all know, immunity is very important. It is the same immunity which mounts a rejection. When we have an organ which does not belong to us in our body does not know it is being kept in for our own good. So our own body recognizes anything which is not ours as foreign, as an enemy, as it were, and it rejects it. To reject it, you need to take anti rejection pills. And anti rejection pills work by completely suppressing your immunity, what you call immunosuppression. So, yes, to sum it up, these are people who have lungs destroyed and reach end stage either because of smoking, which could cause COPD, emphysema, and they go on for many years and then they can't, or it is because of scars in the lung, what we call fibrosis. COVID is one cause for fibrosis, though we will talk about COVID and lung transplant. Lung transplant does not have such a big role in COVID. Young children who have a problem, what is known as a cystic fibrosis, they have recurrent infections in the childhood. There are some problems genetically with them. The lung has not developed very well. And when they reach end stage, you think about it. Yes, sir.
Perfectly said. Perfectly said, Dr. Sundar. And it is something to be considered as a last resort. No question about that. Because, when you know that the probably lifespan of the patient is just about a few months or a year or two, and that too in a very breathless circumstances, where the patient is confined to the room or home because his oxygen levels are such that he's carrying his oxygen with him all the time. And any exertion, even going to the toilet, brings in breathlessness and further fall in oxygen level. These are the situations where the patient is, doesn't see light at the end of this tunnel if he carries on like that. And these are progressive disease. And so we know the end result. And of late, Dr. Sundar, you will agree with me that the prognosis post-transplant has improved in the last couple of decades, whether it is through better techniques, better immunosuppression, but the mortality figures or the survival rates in patients at 1 year, 5 year, 10 year have improved. And the longest survival is, I think, 30, 31 years post-transplant at the moment.
True, true. There have been numerous advances which has helped in the survival, as you said.
Yeah. Dr. Mukesh, what do you think as the selection of a candidate? It's not that somebody who's referred to our clinic, we straight away list those patients to be put as a transplant candidate. We do a lot of tests. We do a lot of course, clinical examination, blood tests, lung functions, and cardiac function, and gastrointestinal, the pH. Lots of things are done before we decide that this is the right candidate to be listed because once the patient is listed, means he is on the no-to list of the national registry and can be considered for transplant anytime thereafter, whenever the donor organ is available. So, is this process of listing rather tedious, and you would like to admit these patients in the hospital for it? So 3-4 days or so to cover all the investigations.
Yeah, Dr. Kanwar, first of all, because the lung transplant surgery itself is very stressful physically and mentally for the recipient. And the post-operative period is also very stormy because there is a two things interplaying in the patient. One is body's tendency to reject, as Dr. SundeR has very clearly told, and the consequent immunosuppressant we administer to the patient, then it predisposes him to get severe infection of many kinds. And there are obviously a lot of antibiotics and other things are supportive therapies are involved. So these stats have been designed in keeping view that the patient should withstand the surgery and should go home alive with the healthy lungs. So there is no point putting healthy lungs in a patient who might not survive the surgery for the post-operative period. Second, regarding your question whether we should admit or not, I will say it really depends on the clinical status of the patient. If we think that the patient we can carry out while the patient is visiting us in outdoor clinic, we can choose to do so. And if we think that the patient is very sick, requires continuous oxygen, and he might not, it is very difficult for him to tolerate daily visit to the clinic and undergo all the tests. So I think we can admit the patient and carry out all that investigation. So it really depends case to case how the patient is.
Okay, Rashmi, it's not easy when finally all the tests are done. This is for the audience. When all the tests are done, and we feel that the patient is probably good for listing, it could be either listed or kept for as a probable listing, or you could feel that the patient is too sick to be listed for transplant, or you may feel that the patient is too early for a transplant. So all those issues have to be considered very carefully, because you don't want to transplant a patient who could probably survive a few years without too much of hassle, and can carry on with the day-to-day activities without too much of discomfort. You probably would like to wait in those patients. But at the same time, if somebody is too sick, then you start to weigh the options of surgical mortality also, as Dr. Mukesh was saying. Dr. SundeR, once you decide to list a patient, let us say you decide, okay, he's 55, 60 years old, I want to have a CAG, I want to be sure about the status of the heart, angiogram should be done. All those reports are brought to you, and you finally decide, well, a thumbs up, he is good for listing, and he can withstand the surgery, and it's the right time. Then from that point on, because the patient, so waiting period may be several months, 6 months, even a year, or even longer, depending on when you get the donor. How would you like to maintain these patients in the optimal condition of the health in general and lungs in particular, through the rehab or whatever you do? What is your regular routine with these patients? I know you do excellent job in these patients, and have experience with one of my patients you operated, and she was in a very poor shape, but you did a wonderful job. She recovered, and I just want to know what is your regular routine on that?
Well, Dr. Kanwar, you touched upon a very important point from the patient perspective. They have been evaluated by the transplant team, and like you said, the transplant team has given a thumbs up and said, yes, sir, you are fit enough to undergo a transplant. Now comes the biggest challenge, the waiting period. One doesn't know when you will get an organ. Now, to put this in very simple terms, the way a transplant team assesses an organ is A, first when a donor offer is come, when there is a donor alert, we check if the blood group matches. If the blood group matches, the next in lungs we look at the size match. For obvious reasons, if the donor, that is the victim, the poor victim of a road traffic accident, who is brain dead and his family have gratefully agreed to donate his organs, if the lung is of a 6 footer and my patient who is 65 years old is only 4 feet tall, that will not fit into him. The lung will be too big. It has got to be squashed to put it to the chest cavity. And the converse also holds good. If there is a young lady who is an unfortunate victim, but who's only 4 feet, to put her lung into a 6 footer becomes a challenge. So, apart from the matching blood group, the size has to match, and then the lung should be of a good quality. The commonest donors, at least in India, are from the unfortunate victims of a road traffic accident. And these are most often end on collision between two vehicles. And in a car, the steering often injures the chest. So if the chest is not
Yeah.
injured, if, if they have not had a vomit which they have inhaled, and before the injury, they were not heavy smokers, greater than 20 pack years. That is, they don't smoke more than, 1 pack a day for completely 20 years, or they don't have ILD or COVID themselves. There is no point in taking a sick lung or a poor lung and doing the operation. The lung has to be good. For that, you do an X-ray, you do a CT scan, you do a test called a bronchoscopy, which is a lighted camera down the lungs to have a good look inside the lung. And you do a lot of tests to make sure the patient doesn't have any diseases which can be transmitted, communicable disease which can be transmitted through blood. Once we ensure that the candidate is good, the organ is good, the blood group is good, and the size match is good, we go for it. Now comes the question, when will this man get a matching organ? It varies. We've got, you know, quite dramatic stories where patients have got it within 1 week. Sometimes there are unfortunate patients who are waiting for more than a year. So what do we do? Once in 3 months, we get them to our outpatient department and we are in close contact with them. We have patients, as Dr. Kanwar said, from Delhi, from Mumbai, from all over the country. And we are very keen once we put them on the list that they will have to relocate to Chennai to live close to our hospital. The reason being, in the worst time of their life, in the times of utmost grief, the family has come forward to donate the organs of their loved ones. All they ask in return is after you take the organs and save many lives, please give back the body of my loved one in a respectable way as soon as possible. So once the donor alert is done, they would quite understandably expect the organ within 10, 12 hours. So for a person staying in Mumbai, he cannot come within the 12 hours. So these people will have to relocate to Chennai. Now, unlike in America, in India, it is so vast and the states are so different. The local language is different from the Hindi that the person from Mumbai or Delhi speaks. That becomes a challenge. And then they will have to wait. So, to allay anxiety, providing they are maintaining the same status of health, we see them once in 3 weeks. However, they are aware if they become more breathless, they have difficulty in breathing, they are unable to do what they were doing few days ago, we ask them to come right away to the hospital. And that way, we will catch any correctable causes, keep them in a good condition, provide and wait for the organ. Having said this, there is a sad fact which everybody has to come around, and that is what we call the mortality while waiting for a transplant. Sadly, there are a percent of people who are not lucky enough to be well enough until an organ is available. So the only thing we can do, as Dr. Kanwar said, is try and maintain their health as much as we possibly can.
Dr. Sundar, some
And
of
for
our
that,
viewers,
yeah,
Dr. Kavan, I would
please.
like to take one question. Like a lot of
Yeah.
our viewers have been texting me non-stop. Like, of course, cigarette smoking is injurious to health, and as Dr. Sundar he has already mentioned that smoking is bad for lungs. But young generation these days, they are taking weight. So what they always tell their parents, like, it's not bad, it's not affecting anything, it has no harm. So what is your take on that? Please let us know.
I'm sorry, the connection wasn't good. The young people are taking.
Vape. They don't smoke the cigar. That's a vape. Like I don't know what.
Oh yes,
Electronic cigarette.
vaping again is not good. Uh, Absolutely, there is no question about it. It is. I presume you are saying vaping,
Yes,
VAPING,
yes,
correct?
yes, yeah.
Yeah.
Yeah. There has been numerous studies which have shown that vaping is not good. NOT not good. I would deflect this question to Dr. Kanwar to see what his views are on this.
No, I agree with you. That's I was nodding my head that vaping is almost as bad as smoking. So in so many different ways. So I will not I will diversify the subject. Otherwise, we can talk for half an hour on vaping and vaping-related injuries in the lungs. So that is a little different kind of injury than the smoking. So yeah, this waitlist mortality that you mentioned, it's a global problem. Rashmi, it's a problem in the USA also. I mean, people, a good percentage of people, they don't get the organ and they don't survive that period. So that is something which all the governments are trying their best to reduce the waiting period as much as possible and maintain the patients in the best possible health. And Dr. Sundar, I thought you would be talking about the rehab that you're, advocating very aggressively in those patients who are waiting to keep their lung health in optimal condition.
Yes, yes. I will at the risk of this sounding like a science class, I will have to point out a few things. And once your audience gets the hang of it, you will then realize what our rehab program is all about.
Yeah.
Now, everybody, commonly, any person, walking down the street, you go and ask them, what is breathing and which organ does it? The answer is lung.
Of course.
They are only partly correct. They're only partly correct. So the breathing is the result of two organ systems. One is the muscle, the next is the lung. The lung does a great job, as every one of us who've done our biology or science in school knows. The lung takes oxygen inside from the air. It becomes a red blood or a pure blood, though scientifically there is no pure or impure blood. Now, that red blood goes to all over the body. The body uses them. You have a waste product called carbon dioxide. That becomes the blue blood. This we all know. And the lung breathes it out. Even this we all know. But what we don't know is for the lung to work, to take oxygen and give out carbon dioxide is what doctors call gas exchange. For that to work, the air from the outside, which is in the atmosphere, needs to be transported into the lung. The lung can only work with whatever air it has inside it. Air which is outside the body has to be transported to the lung to work. And which part does it? The muscles. You take in a deep breath, you breathe out. So breathing in, breathing out are muscles. So if the muscle does a good job and gets the air in, the air having deposited in the lung is exchanged by the lung. So 50% muscle, 50% lung is what breathing is all about. Now, as a transplant surgeon, I can only fix the lungs, not the muscles. So the patient's muscular strength should be maintained so that after I put in the new lung, he must be able to breathe in and breathe out well. Now, the act of breathing in and breathing out, we medicos call them ventilating. You, Dr. Kanwar, Dr. Mukesh Goel, we are all self ventilating. We are ventilating for ourselves by our muscle. Now, when a patient becomes so weak and he can't breathe in, we use a machine, not surprisingly called a ventilator, because it does ventilating for us. So, during waiting, we insist on physical rehabilitation to make sure we keep his muscles active, nutritional rehabilitation so that he has enough energy on board, using which his muscles can be developed, and of course, pulmonary rehabilitation to the extent possible. Now, once we do all this, we keep him in the best nick of his physical health so that once the transplant is done, he just bounces off and, everyone is happy and laughing.
Great. Dr. Sundar, you can actually take a kids class also.
Yeah,
You
he's
make it
so
look so
good.
simple.
He's
You make it
explaining
look
it
so
such a
simple.
beautiful manner. Yeah, of
Yeah,
course.
it's a very complex subject, Rashmi. It's a very
Yeah, our
complex
viewers
subject.
are
But
loving this show and they're so happy. You know, they're understanding it so
I'm
well.
glad Dr. Sundar has made it look easy. But let me also tell you, it may be a little heavy for the audience. So just to take them a little away for a few seconds, Rashmi, Dr. Sundar is very jealous of me.
Oh, really?
He says, yeah, he says, Manjeet, how is it that you're on these shows as your extracurricular activities? Now, Sundar, I want to tell you that the person who took me into that arena is sitting before you, Rashmi Bedi, and Janak Bedi, who's controlling the show. So
I will have to say a double hi to Rashmi.
Thank you, Dr. Sundar. Thank you
so
so much. Our viewers are loving our
well,
show today. They're so happy because it's really very informative session today, and of course, lung play a very important role in our lives, of course, and how to keep them healthy. And they're texting me, "Oh, yoga is so important. Now we know why we need to do yoga and exercise and all." It really plays really important part, of course. Lungs, we need to keep them healthy, and of course, the muscles, what Dr. Sundar is mentioning, amazing. So good to know.
but I must again remind you that every time I'm going to be a judge in your beauty pageants, Sundar is going to watch and feel more jealous.
Indeed so. Indeed so.
So I can see two more contestants here, Dr. Sundar and Dr. Goel, of course. They both are amazing, and how nice. Like, of course, as I mentioned before, you are our heroes. Of course, a big salute to all of you. Amazing you all are. And of course, you always motivate others that never lose hope, never give up. That's what it is all about. So thank you so much.
Never give up. Never give up. Never give up. Yeah. Just to carry on with the subject, for we have another 5-7 minutes more. Dr. Mukesh, like Dr. Sundar was telling you about the ventilator in those patients who cannot breathe in and out enough, or the work of breathing is so high that they tire themselves out, cannot maintain their gases. Sometimes, even with 100% oxygen, we are not able to maintain the patient on the ventilator. We are doing everything, still the oxygen is falling or in a range which can be catastrophic. In that situation, we use a sort of a heart lung machine, Rashmi, which is like a bridge. If you are going to transplant that patient, it gives you a lease of life and probably maintain you till the time you can get a donor. I mean, if you can, maintain for that period. Also, until the lungs regenerate from a reversible process in the lung, whether it is infection, which once gets treated in a week or so, a couple of weeks, and the function improves, then you can take the patient off that machine. I want Dr. Mukesh to tell us about that machine, ECMO, the extracorporeal membrane oxygenator. Please, because he's good at that, and he puts lots of patients on ECMO machine. Please, Dr. Mukesh, tell us about that.
So, as Dr. SundeR had just outlined what is a ventilator, that which ventilates, but ultimately oxygenation is done by the lungs only. And what Dr. Manjeet here is talking about, that the lungs are so diseased and they are so ravaged that despite the